Good evening, my patient advocate friends. My apologies from Untangled Healthcare. We had planned on doing this about a month ago. This is part 2 in a 4-part series on patient advocacy, and we're just now doing piece 2. If any of you have questions, please do not hesitate to email me at jeffharris@untangledhealthcare.com, or you can look at our LinkedIn account, our blog, and of course our SlideShare account, where you will be able to download this particular presentation. Reviewing your syllabus, you will find that tonight we're on the support, advocates process, and use case, and we'll go ahead and move on from here. This graphic is the Untangled Health illustration of your care cycle, which includes assessing and planning, educating, coordinating, and monitoring the patient and family, and the various levels of assistance that an individual requires as they age. You'll notice that it includes usual care, self-services, supported self-management, care coordination, and case management, requiring more and more people to assist the patient with their activities of daily living as they become progressively debilitated. If you take the entire graph and shift it to the left, it models essentially what you would see in a pediatric case where a pre-adolescent child develops diabetes or asthma. This graphic further defines your patient advocate process. It's one of discovery, wherein you discover all of the data points that you can around the patient's and family's biopsycho and social history, their goals, their wants, and their needs, activating them with a payment system and a medical home, assisting them with identifying community resources and their peer structures that will support them, educating them, evaluating them in terms of learning barriers and whether or not they are reaching their knowledge goals that you have set for them, and then monitoring. Eventually we hope that they become independent and you can sign them off and they can re-engage you at times in the future if they sense a need for your services due to a loss of control of an existing condition or perhaps the development of a new one. During your discovery phase, you're going to be interested in 4 primary issues. 1, can the individual master their own illness? 2, how stable are they from a psychosocial perspective? In other words, do they have financial solvency? Are they depressed? Do they have a substance abuse program? Do members in their family have substance abuse programs? These are all pertinent factors in terms of stability with regard to a person that is ill either for an episode or for a lifetime. And the patient's knowledge with regard to the illness that they are caring for at the time, and functional status dimensions. When we speak to the dimensions of one's functional status or functional domains, you'll note that we make reference to cognition, in other words, a person's capacity to solve problems and remember, psychosocial issues such as emotional status and adjustment to limitations, communication with regard to an ability to express a person's needs, comprehend instructions or read instructions, elimination, which involves bowel and bladder control, self-care, can they eat, can they groom, bathe, dress, toilet, and swallow, and then again mobility. These are higher levels which require an individual to actually be mobile within the community, not just within their own home, such as transferring from a toilet to a shower, but also driving a car, walking, using a wheelchair, and so on. On activating the patient, you want to connect them with insurance programs. Here are some examples: Medicaid, safety net sliding fee, and the forthcoming insurance exchanges. Obviously, if they fall between eligibility criteria, you'll want to contact your local Department of Social Services. You want to make sure that the patient is in contract with a primary care physician that offers up a primary care medical home These can be differentiated by looking for certifications from various agencies. In the near future, we will have a Medicare primary care medical home, and we currently have an NCQA Bridges to Excellence medical home. During the first visit, you would like for the individual to be in contract, which is signed with that physician, and that contract states that what they will do is call the physician's office first prior to using other resources unless they feel as though they are having a life-threatening event. You want to make sure that follow-up dates and responsibilities are set between the physician and the patient and their family, and help to coach them along during that process. This slide is the evaluation process, showing that during a review, in the initial review of the patient, that you're going to make sure they add you to the care team so that you can have access to their records and take a look at what's been going on and give them a hand with setting priorities. And their priorities typically for you should be that their medications are reconciled, their appointments are being completed on time, that their testing is being completed on time, that they're starting to make lifestyle changes, and you should be able to take a look at their use of emergency room services. If that seems to be going down, that's good. If it seems to be increasing, you want to find out what the precipitating factors are, and you always want to look to see if the medications they're taking are on their insurance formulary, and if they are, what tier they're on, so that you can see whether or not they can be moved to a lower cost tier for a lower total annual expense by the patient and the family. Always look for any type of changes in physical, functional change, or any cognitive change, such as memory, especially in the elderly, because these folks fall a lot, usually because of, one, the medicines they're taking, and two, changes in visual acuity. Here's a real-life example. Here's an individual that came to our home who needed help. She was a victim of domestic violence, had transitioned from military to public health systems, was treated by 12 physicians in another state, and surgeons and behavioral health specialists, was placed on 22 different medications. All of them are stacked in front of you there. She lost her ability to think clearly, she lost her family, and she became homeless. After our evaluation, we performed patient classification into biopsychosocial and functional domains. You can see here that we determined that she had complex comorbidities, including degenerative spinal disease and a possible traumatic brain injury, that she had a history of substance abuse and post-traumatic stress disorder, that she was financially impoverished and was homeless, that she was also a well-educated individual in the behavioral health sciences, and that she had a cognitive defect with memory and executive function, and had severe chronic pain that limited her locomotion and her ability to get about in society. So a summary is that she couldn't work, she couldn't drive, she couldn't think, and she had no hope. Had this patient shown up with this status and not known of the availability of an advocacy service, she probably would have been found on a park bench. In that park bench, she would have been turned over to the police and then to a hospital through the ambulance. The ambulance would then put her to the acute care hospital, where the acute care hospital would discharge her within the shortest discharge planning framework that they could put together to get her to the next lower level of care. This classic scenario is usually managed with extremely poor transition management and communication between physicians and facilities, and often is caught by us as a recurring revolving door scenario that evolves in our society. You can stop this. It's within your purview if you help the person to teach them how to, one, be safe, and two, care for themselves. During the discovery process, what the care advocate is interested in is the history of sentinel information, such as diagnosis, procedures, providers, medications, and episodes of hospitalization. What you want to try to facilitate, of course, is to store these data as you create the health record for the patient on secure online repositories. In this case, our individual was a Medicare recipient, so we were able to, through her permission, gain access to her claims history and tease out the clinical data from those claims to start putting together our care plan. A more in-depth evaluation will show you how the information flowed in our initial discovery phase. We went online to cms.org and opened up the patient's claims data and then exported those data to the Microsoft Health Vault after creating an account for the patient. When we set up Health Vault, we also set up Health Vault to speak to the CVS pharmacy chain, and in the future what will happen is as the patient fills their prescriptions and has prescriptions written, you will be able to determine within Health Vault the prescription history and any gaps in prescriptions that might be evident through analysis of them in a longitudinal sense. All of these data are then presented through the primary portal to the patient. This is the Mayo Clinic Health Manager. It's free. We like it a lot, and there are plenty of other products on the market that you can find that your patients would probably use. The final outcome, we had combined Mayo PHR with a manual clinical summary. We transported the patient to the UNC Healthcare with summary documents and films. And then we had a connectivity that looked similar to this graphic, where the patient was the center of a hub of information that included Medicare claims, Mayo personal health information, the CVS pharmacy system, Health Vault, which also has connections to laboratory systems folks, and to the University of North Carolina. The patient care team today is a primary care MD, a psychiatrist, a physiatrist helping her with her physical disabilities, and a behavioral health program. She uses a portable health record which includes medications, and when she started seeing us, her medications were greater than 20, and today with her coordinated care team, she's now on less than 8 medications. She's completely independent, driving a car, able to self-transport, and she states that her self-perceived health status has improved greatly. So in any advocacy organization, what you need to remember is you're going to meet the individual and a family. You're going to have to tether things together for a very brief period of time just to keep people calm, and then start locating all the clinical and treatment data that you can, organizing those data, and coordinating a comprehensive care plan. Those services can be done using tools that are based on the web through various insurance companies and the Centers for Medicaid and Medicare Services, as well as other organizations. And I suggest that you take advantage of them as you move along, because it will make you more efficient. You won't need to paw through as many paper documents as you're used to. In the end, you will have several care plan elements that you report recurrently until you sign off the case, including impairments, disability, handicaps, and how you're addressing them. And eventually the patient and the providers will be comfortable with their own interactions, and they'll find that they do not need your services any longer, and that's an appropriate time to sign off the case. You notice that your plan of care is really no different than you would see in a nursing plan of care, where you have a problem, a treating professional, a goal, and a date for next appointment. This then acts as a schedule for the patient themselves. In the next session, which we hope to have done in the next week or two, it's actually done, we just need to record it, we will get into the concept of personal health records in terms of selection, components, security, and the process for implementing one. Bless you all, and have a wonderful Thanksgiving. Good night.